And now we're going to do GI. And GI, we got some classic GI considerations. Let's see, where's my GI? And you know what we're going to start off with first is good old gastroenteritis, okay? And you know how important that is. Kids can get very dehydrated very quickly. So when we think of gastroenteritis, we know that it's vomiting, diarrhea, nausea, abdominal pain. Often it's with children who have been, what, involved in daycare, around other children who have been ill. We do know it can be viral, bacterial. You can also think about parasitic or maybe inorganic food contents, emotional stress, lots of reasons that can cause gastroenteritis. We pretty much have all probably experienced gastroenteritis from time to time, fairly familiar with the signs and symptoms. General sick feeling, anorexic, crampy abdominal pain. And what we're concerned about is the kid that has gastroenteritis and what level of dehydration. If you'll think about it, look at mild, moderate, and severe. Very close, right? 3 to 5, 6 to 9, more than 10. Boy, just a slight little change can move you from mild, moderate to severe. And if you'll think about it, your hemodynamic factors, your blood pressure, pulse, cap refill, pretty much kind of work together. And then you got your skin turgor and your fontanelles. Hopefully, if you have a very young child, you can look to see if they're depressed. And then urine. When you think about, and I always think about fontanelles. I remember when my daughter had her first baby, she called me up and she'd say, it's pulsating, Mom. You know, she thought that was bad. You know how people, so you have to reassure them, you know what I'm saying? You know, that it's an okay thing, that it pulsates, it moves a little bit, you know what I'm saying? But urine, a lot of times we're not measuring urine like this, but we look at diaper counts, okay? So you think about, you know, are they having, if it's say a 8-month-old that is down to maybe 3 diapers a day, 2 or 3 diapers, probably not putting out enough urine. You see what I'm saying? So you want to think about where are they in that perspective. Diagnostically, stool for guaiac, O&P culture, white blood cell, we really don't need to do anything unless, though, it's more than 72 hours that they have blood in the stool. But we don't always see blood in the stool. It has to be, that's actually very frank blood. Now, what about management? Well, daycare exclusion, what we're supposed to do, what we don't always do, is before a child can return back to school, daycare, or whatever, they're supposed to have 2 negative stool cultures prior to return. You know we're not doing that consistently, right? You know that. Frequently, and again, what is the test all about? The test is about following standards of practice, right? Frequent supportive therapy is often, that's all it's needed. Breastfeeding formula should be continued. This is not the time that you want to do a lot of change-ups in their nutritional support. But I will tell you, oral rehydration therapy may be needed. What this means is when you have a child that's dehydrated who may have what? Electrolyte imbalances, you don't want to too quickly, massively give them too much fluid. So if they're moderate, say between 6 and 9% of their weight, they're showing some dehydration, 50 mLs of fluid per hour would be appropriate. Severe, you could bump up to 100. Regular diet. Now, I know a lot of you think about the brat diet. Now, I'm going to tell you, it's kind of lost favor. The brat diet, banana rice, applesauce toast, is not necessary, but you know what? It resonates with people. People can understand brat diet. The other day I had a parent come in with a child, and the child was a young child, and it had a lot of loose stools and everything. It was nauseous, and I asked them what the child had eaten for dinner last night, and the mother goes, well, he had Salisbury steak and mashed potatoes and gravy and corn, and I'm thinking, no wonder his stomach is upset. People don't understand that you got to let the gut rest. So that's why it's easy to teach people those 4 items. But the reason it's lost favor, and they say a regular diet is gradually resumed after the patient's rehydrated, whatever you can get down them is appropriate, other than heavy things like corn and gravy and, Salisbury steak. You see what I'm saying? So if they can take, if they could eat maybe some oatmeal, some yogurt, it doesn't have to be just bananas, rice, applesauce, and toast. Antimotility drugs, such as loperamide, which is Imodium, We do not use, or we use very judiciously, because you want to make sure it doesn't mask anything in terms of the disease process or prolong the illness. And you really shouldn't use it in fever or bloody stools, because you want to get to the, you want to do what? You don't want to stop whatever the organ is. You want to get it out of the system. So you want that to occur. Antibiotics, pretty much consider a patient experiences more than 8 to 10 stools a day. First drug of choice, we use good old Bactrim. Bactrim is used very appropriately. It's indicated when an organism, except for Salmonella. You know what? Salmonella doesn't participate very well. It really doesn't, it's not real responsive to antibiotics. And usually that one has to just run its course. As a matter of fact, when I was a brand new nurse practitioner at the University of Alabama in Birmingham, I was in practice, and at the local hospital, the university hospital, there was an outbreak where 7 newborns got exposed to Salmonella. Guess what Salmonella does? Salmonella erodes the gut. It erodes the villi, the V-I-L-L-I, that allows for the absorption. So you know these kids developed an organic failure to thrive for several weeks before they could resume and get back to normal. So you guys think about what you would do for gastro, and that's usually a real common pink pig kind of a consideration, because it's mainly based on the dehydration side. Let's talk about GERD. Are you going to see GERD in primary care? Oh my goodness, right? We're going to see it across the lifespan. We're going to see it with our newborns, maybe our school-age kids, and maybe, of course, our adults, for those of you who are F&Ps. So we think about GERD is where the lower esophageal sphincter allows gastric contents to kind of slip past it. There's 3 classes. You've got physiological, functional, and pathological, and they're kind of different. Physiological is infrequent, episodic. Functional, painless, effortless, no sequelae. But what you're worried about is kids that are going to aspirate or become failure to thrive. If you'll note here, 85% of preemies and many infants who are low birth weight, typically you will see this as a common etiology. And often it can be resolved by about the time they're 18 months. But a lot of kids, you know, you get the kid that's a school ager, that you get these kids that seem to clear their throat all the time or have like a cough unassociated with an infection. You might want to raise a flag whether or not, if they had it as a baby, has it returned, what are they eating? You know, it's the same thing you would do with your adults. H. pylori in children of color is very common. As a matter of fact, 30% or more is a common etiology. And you know, if you suspect H. pylori, they need to see a GI specialist. Some of the things you think about, signs and symptoms: choking, coughing, wheezing, weight loss, irritability, heartburn, stool pattern changes. Pretty much need a good workup like a CBC, because you want to make sure they're not becoming anemic. UA culture, blood, stool for occult blood, and an abdominal ultrasound to rule out pyloric stenosis. But you know what? We haven't done pyloric stenosis, but pyloric stenosis is going to be more projectile vomiting. I mean, it's not going to be a little bit of a, you know, of a spit up or something, but it's going to be more prominent. And did you know, too, I wanted to just make another little sidebar. Ultrasonography is really finding a big role in today's healthcare, much more than running off and getting CT scans and things like this, because it's, what is one of the rules for our decision making? The least invasive, least expensive test that will give you the knowledge you're going to give. And always ask yourself, when you order a test, is the test I'm going to order going to change what I'm going to do for this patient? And that will stop you sometime. I am myself becoming much more aware of what I order, because I am tired of contributing to these huge healthcare costs. Patients come in, they tell you that they want a CT of this, that, and yonder, and you say you don't need a CT. You know, I'm not going to change what I'm going to do for you based on a CT, and plus I'm exposing you to what? I'm exposing you to X-ray. So you see what I'm saying? And so you want to always keep that at the forefront. Now, the way we manage is small frequent feeds, burping them, you know, positioning, elevating head of the bed. This is an interesting thing here, and they've even done a little study for this, but if you give them a little bit of weight to the formula that they're taking, maybe that'll help keep that formula down so it's not as easy to return. And they've even studied that. There was even somebody that was saying that's going to contribute to obesity. It's probably not going to contribute to obesity, but, you know, somebody has to study it. Now, medications, your H2 blockers like Pepcid AC and Santac can be utilized. PPIs, you know, PPIs have gotten a lot of press lately because PPIs have been known to do what? To contribute to anemia. But, you know, in kids, PPIs, if you need somebody to go on a PPI, probably in a pediatric patient, you probably need to go ahead and refer them over to who? To the GI specialist, so you can make sure it's an appropriate diagnosis. We do much more PPI management with our older adults, but for kids, you probably need to refer to a GI specialist. So let's talk about pyloric stenosis. This is the one that you think about with, and I think this is always interesting, 1 in 500 infants. And remember earlier we said sickle cell, 1 in 400, so it's pretty prevalent. And the pylorus is thickened, and this may run in families. Breastfeeding delays it, but you'll think about it, it usually is in that younger infant, say 3 weeks to 4 months. Projectile non-bilious vomiting after they eat. They come across being very hungry after vomiting, poor weight gain, weight loss, eventually become dehydrated. Peristaltic waves are visible, and that palpable pyloric mass, after they've had vomited, you can actually feel the rubbery mass, the pyloric mass itself. Now this is, when you think about what kind of diagnostics would you do? Well, probably an ultrasound would be good. And if the ultrasound is really not giving you much information, but you got so many clinical findings that make you think, oh, this is pyloric stenosis, and you have to do an upper GI, have that arranged, there is something called a string sign, which is a narrowed pyloric channel. There it is, right there. That is very classically noted on a child that who has pyloric stenosis. So what are you going to do with these kids? Send them to surgery. They get surgery. Prognosis is usually quite good. Okay? How you like this term? Intussusception. You just kind of roll that one off your tongue, right? And this is where you have prolapse of the intestine into the lumen. This is a very serious matter. You know why? If you have part of the bowel prolapsed, and it's going to cut off the blood supply in the mesentery. So this can become a surgical emergency. We will try to treat it non-surgically first. Runs in young children. This is an infant who was previously healthy, non-bilious vomiting, lethargy. I'm going to come back to this current jelly stool for a minute. But they have this mass in their right upper quadrant, and they get progressively tender, and they can lead to perforation and shock. Remember I mentioned I was going to come back to current jelly stool? In a few moments we're going to talk about Hirschsprung's disease. Hirschsprung's disease is where it's an aganglionic megacolon. So the stool sits in the bowel. When you have stool sitting in your bowel and it just sits there and it builds up pressure, it pushes on the blood supply in the lumen of the intestine, and guess what seeps into the bowel? Blood. And that is because it's been there for a while. But let me tell you, these kids are hurting. This is an acute abdomen kid. This is a kid that is not, you're not going to have this kid sitting around too long before you do something, because they've been healthy and then all of a sudden something happens. And again, if you just gave them a what? A rotavirus, 3 to 4 weeks after that, you also want to think about, could that be a cause? Because I said they could still cause it. X-rays are done. Barium enema is diagnostic and may even produce reduction of the bowel. But if it goes back in, becomes prolapsed, then you want to consider surgery after that. Okay? It can be fatal. So this is a very serious matter if they're not intervened properly. So this brings us to Hirschsprung's. Now, this is one F&Ps that you might want to think about. I don't know that they're going to really ask on the F&P exam as much about Hirschsprung's, but let's just talk about it conceptually for a minute. PNPs, this has been on your exam. This is why we added it in. Hirschsprung's is a multifactorial familial condition. If untreated, may develop enterocolitis, and it can be fatal. Basically, what you have is, this is kind of nice to know information, more in boys than girls, infancy, older children, 1 in 5,000 births, so it's not real common. But these are kids, the other term for Hirschsprung's is aganglionic megacolon. Does that make sense? So that means that the colon becomes enlarged because the nerves that were innervating it and allowing it to, pass stool isn't working. So that's what that means. They'll have bilious vomiting. Do you see the word bilious? Anytime you guys see bilious, that's a serious matter. Bilious could be a small bowel obstruction. It could also be volvulus, malrotation. Before we got into Hirschsprung's, all of our vomiting was non-bilious. Remember with pyloric stenosis, it was projectile non-bilious. So it's jaundice, infrequent explosive bowel movements. Isn't this a lovely subject matter to talk about after lunch? Progressive abdominal distension, tight anal sphincter with an empty rectum because the stool isn't passing. Failure to thrive in malnutrition. X-rays, barium enema, and a rectal colon biopsy may be ordered, and you definitely need to refer these kids over to GI. Okay? Mainly if pediatric folks, if they were going to ask something about that, it would be more about the symptomatology that was presented. Appendicitis. Okay. Appendicitis is pretty much presents, there's nothing different between kids and adults. But appendicitis, inflammation of the appendix, due to a foreign body inflammation, and it usually, if untreated, gangrene and perforation may develop in 36 hours. You know, you have that person that calls your office and said, I'm hurting around my abdomen in the middle, and then it shifts, and I'm running a little bit of a low-grade fever. I have a little bit, you know, I'm having some bowel irregularities. By the time they get to you, because they stalled getting in to see you, then they say all the pain's gone. That's the person you should be worried about, because the pain is the pre-rupture that's going to be presented. So you want to think about, it's common in school-age kids. Look at the signs and symptoms. It starts in the colicky umbilical pain. It shifts in a couple of hours to the right lower quadrant. You have abdominal tenderness. Now, the psoas and the obturator sign, please put a little yellow thing next to it. Those are confirmatory findings. You know what the psoas sign is? That's if you have the patient, you have them lying down, you're examining them. You ask them to raise their leg, and you try to push on that leg as they're trying to push up. That's causing that psoas muscle to be irritated. The obturator is when you internally rotate the leg, you're looking at the thigh. Does that make sense? Those are classic confirmatory. So if you get a test question that says you have a positive psoas and a positive obturator, cha-ching, appendicitis. It should be pretty much the answer. McBurney's point tenderness. That is where you've got that line that goes across from the umbilicus down towards the thigh, and you've got pain along in the middle area. So that kind of links to coming from the periumbilical and then moving into the right lower quadrant. That's showing you where the pain is migrating. Pain worsens with anything that increases pressure, such as a cough, nausea, vomiting, sense of constipation, fever, low grade. Your WBCs will be elevated. Usually, again, you know, this is a tough one because a lot of times we have to go to a CT with contrast. And why do we do contrast? Is so we can see what? All the different layers, the different organs, and so forth. So usually that will give you more information. You need surgery. Prognosis is usually very good. Hopefully you've gotten it before there's any type of massive infection. Malabsorption. Boy, if you've ever had somebody with malabsorption, very difficult to manage. Malabsorption, impaired intestinal absorption, essential in nutrients, and we know we see it in conditions like cystic fibrosis. We think about celiac disease or sprue, gluten intolerance. And don't we have a lot, and when you go to the grocery store now, you have like rows of food that's gluten-free, right? So that's become very popular. We also think about infectious agents and anything that might affect the mucosa of the intestine. When you think about somebody that has a malabsorption condition, they look like a child that may have some ascites, emaciated extremities. Remember the term steatorrhea? Do you all remember that word? That is associated with this severe chronic diarrhea, bulky foul stools, often seen with kids with cystic fibrosis. Y'all remember that term? And vomiting, abdominal pain, and protuberant abdomen. And of course, when you are malabsorbed, remember those babies at the university hospital that I worked at? They got salmonella. Well, they're not going to be able to do what? Absorb their food, so they're going to have lots of vitamin deficiencies. And a lot of times you'll see it with their skin, hair, nails, peripheral neuropathies. They need a pretty good workup, don't they? Stool, lab work, bone age. You're thinking about, could it possibly be H. pylori? Could it be cystic fibrosis, doing a sweat test? So they need a really good workup. Some of the differential diagnoses, pretty obvious, like your cystic fibrosis, hepatic disease, IBD, inflammatory bowel disease, or celiac disease. Pretty much what you would do while you're working them up, if you find something that's an infection, you treat that enterically. We think about dietary modifications, no wheat, oats, rye, and barley for celiac disease. Cystic fibrosis, what are the pancreatic enzymes that are missing? Do y'all remember there's 3 of them? Lipase, amylase, and something that doesn't sound like that. Trypsin. Remember those 3? So we would have to replace those. And then, of course, we know fat-soluble vitamins such as A, D, E, and K. And you're probably going to refer them to gastroenterology. Here is neuroblastoma. Neuroblastoma, more for the pediatric folks. Tumor arising out of neural tissue, frequently at the adrenal gland, can spread to other associated areas like liver, lymph nodes, skin, and the orbits of the eye. Pretty much with an individual that has this, it's seen before the age of 5. Enlarged abdominal mass, profuse sweating, tachycardia, and their urine catecholamines would be elevated. Probably an abdominal CT would be beneficial here, and a surgical biopsy. So we want to think about neuroblastoma. That really needs to be referred over to a pediatric oncologist. Usually the question, if they ask something, is more on the pediatric exam, and they've asked things similar to some of the diagnostics that would be ordered. Now, what about hepatitis? Hepatitis is, as you know, inflammation of the liver resulting in liver dysfunction, and we've got several different types. It can be self-limiting, and I think of self-limiting like hepatitis A, right, to something much more severe and profound, such as in hepatitis C, even though we have treatment for it, but the treatment can be more difficult, or hepatitis B. The ones that I'm going to review with you today is A, B, and C. And I wanted to, before I even go into starting into each one, let's think about what's different between kids and adults, okay? It takes to about like the age of 10 by the time the liver is fully at the adult level of functioning and size. So when you have a child that's, say, younger than 10, oftentimes a child that has been exposed to one of these hepatitis conditions and they develop A, B, or C, they are often going to be what? Anictric, without the ictric changes, the skin yellowing, the eye yellowing. But I will also tell you, hepatitis A as a whole, you don't see a lot of yellowing with that anyways. But I wanted you to understand that basic difference. And we also know that common source outbreak with contaminated food and water, shellfish, doesn't have a very long incubation period. There's no chronic state, and mortality is rare. And what do we have now? We have a vaccine. And I know that we talked about focusing in on babies between 1 and 2 years of age, but anybody can benefit from it. If you like to travel into other countries and eat ethnic food and things like that, it's a good benefit to get that vaccine. We know hepatitis B. We have a wonderful vaccine series for this. It's bloodborne, found in saliva, semen, vaginal secretions. It is transmitted through these blood and body products, sexual activity. And you all probably know vertical transmission means what? Mother to baby. Incubation, 6 weeks, 6 months. Often it's considered insidious, meaning it's kind of slow. You have to really look for it. I always think about insidious when I think about with diabetes. You know, a lot of people have diabetes type 2, don't know they have it, because they could be developing the symptoms over time, right? So that's what insidious means. But if you have somebody that has hepatitis B, the risk of fulminant hepatitis, which is the more serious type, which has a high mortality, is low. But look at the mortality rate, 60%, that's huge, right? This is why it's so important that we focus in on getting that series of 3 hepatitis B vaccines and even doing serology testing to see if they've converted appropriately. Here's hepatitis C. Blood transfusion, 50% of cases are IV drug use. Pretty much that mother-baby transmission, sexual transmission is low or rare. Incubation period's variable, but it's pretty much 4 to 12 weeks. And what you want to think about is some of the signs and symptoms. Now, let's get into these if somebody were to show the different changes like the skin coloring. Pre-icteric fatigue, malaise, anorexia, headache, and they'll tell you that during this phase, before they turn yellow, they'll say, you know, foods that were sweet taste salty, and salty foods taste sweet, and things, their taste change. They have a lot of food aversions. When they go into the icteric phase, this is when they lose weight, have jaundice. Why do they have jaundice? It's because now the bilirubin's building up in the skin. What about pruritus? Bilirubin stores in the skin, and it's highly pruritic. We also know right upper quadrant pain, the stool characteristics, clay-colored dark urine, and low-grade fever. Enlarged liver and spleen, and they'll have some diffuse abdominal pain, and especially tenderness over the liver area. And of course, as you do your labs, CBC-UA and your liver enzymes, particularly your AST and ALT, they typically, for those that are going to have some of the icteric changes, they will rise prior to that. So it's like in that first phase. And then as soon as jaundice appears, their AST and ALT will drop down. Okay? Now, you know serology testing is going to be something that you may order. I will tell you, typically, the serology testing questions are offered on the adult. For the family folks, you'll have questions associated with adults. Pediatrics, they don't ask a lot of serology tests questions. But let's just take a moment and look at this. You're going to have kids that are active, recovering, or chronic. Anybody that's active, they're going to show, you're going to be able to pick up the antibodies, right? And IgM means immediate. IgM right now, here in the now, your IgM will be positive. But somebody that's recovered in the past, they're going to have IgG. That IgG will always be present as being notable for them having had hepatitis. And this one right here, which is the this says active hepatitis B, HBe antigen, that is picking up right now at the time that the child is probably replicating the virus. So they're actively making more virus at that time. That was the, okay, you were looking down, and this is right here. HBe antigen. When you have that really kicking into gear, that is probably saying, you know, this child is really replicating some of this virus at this time. Absolutely. So what do we do? Generally, it's supportive, increased fluids, vitamin K to help with the PT. You want to rest that liver. You don't want things that are going to be causing the liver to be taxed, like medications that are liver processed or alcohol. One of the meds, you know, would be Tylenol is a good one to think about. You want to really have them on a more no or low protein diet because it takes a lot more of the liver processing to process the protein. And if you've ever had somebody with hepatitis C that had to be treated, oh my goodness, sometimes the treatment can be far worse than the actual condition. They are extremely malaise, anorexic, no energy, and so on and so forth. So for that chapter, you know, they're probably going to ask you something on something structural like either pyloric stenosis or intussusception. They love gastroenteritis for the dehydration. Malabsorption and appendicitis, it's just a toss-up whether or not they're going to ask that. And usually the hepatitis is usually reserved for the adult questions. But just in case you got one, I wanted you to know about the anecdote.